Hello, everyone, and welcome to AAKP's Policy Summit, Patient Voice, Patient Choice, New Determinants for Kidney Policy. I'm Richard Knight, Immediate Past President of the AAKP. On a personal basis, I'm a former dialysis patient and 16 years out on my kidney transplant. Professionally, I work as an adjunct professor teaching courses in management and business strategy. Much of my background is in the public policy arena, working at congressional operations based on my experience on Capitol Hill, where I served in various roles including communication, policy, and as a legislative director. While working in the U.S. House of Representatives as a top aide to a congressional leader, I had the privilege to serve as liaison to the Congressional Black Caucus and was involved in significant policy work with the House Energy and Commerce and Small Business Committees. These experiences have provided me with a framework and a background with a valuable set of skills that I've put to use for AAKP on kidney policy issues over the past decade. However, you do not need to be a professional policy expert to get involved in the policy process. You simply need to be an informed patient. Take the time to study important issues that affect you and your fellow patients, and take advantage of AAKP's free online advocacy engagement skill development training programs. Your voice and your vote can lead to important changes. If you are not a member of AAKP, please join us. Our membership is free. Just go to the link shown at the bottom of the page and sign up today. Furthermore, I want to encourage you to sign up for AAKP's alerts to AAKP's Action Center at the website that's now showing at the bottom of your screen. AAKP will keep you up to date about latest policy issues that affect patient care, and with one click, you will be able to contact your state representative, federal agency leaders, and many more who need to hear your perspective and your unique patient insights. Now, I'd like to introduce our session titled Vital Signals, Kidney Stakeholder Policy Priorities Impacting Patients. We're honored to have 4 individuals who are joining us who represent various organizations that work alongside the kidney community and other disease communities on important policy issues. AAKP is very interested in their perspectives and their views on issues of mutual concern. To get us started, I'd like to welcome a good friend and collaborator to AAKP, Sara Traigle van Geertruyden. She's Executive Director for the Partnership to Improve Patient Care, better known as PIPC. PIPC is a broad-based collaborative of nearly 150 allied patient and disability rights organizations. The chair of PIPC is former U.S. House of Representative Whip Tony Coelho, a strong patient advocate who worked in a bipartisan manner with President George H.W. Bush to establish the Americans with Disability Act 20 years ago. AAKP is proud to work with PIPC to oppose the establishment of anti-patient and discriminatory quality-adjusted life year metrics in federal health programs. These subjective measures, they tend to discriminate against patients with chronic diseases like kidney disease, like kidney patients, because they are used to determine your access to new medications and devices based on their cost and the estimated length of your life. Sara, without further ado, take it away.
Hi, thank you so much for having me here today. My name is Sara van Geertruyden. I'm the Executive Director of the Partnership to Improve Patient Care. I'm excited to be here today to talk to you a little bit more about the use of the metric called the Quality Adjusted Life Year and its implications for discrimination and health equity. So as some of you may know, the Partnership to Improve Patient Care is a coalition that was created way back when comparative effectiveness research was a hot topic in Congress back around 2008, 2009. As an organization, we fought for the creation of the Patient-Centered Outcomes Research Institute an entity that puts patients and people with disabilities at the center of their work and engages them at every step of the research process. PIPC's members were very frustrated that research didn't necessarily include people with disabilities, people with the conditions that were being discussed in the process of designing research. And so what they wanted was research that was really informed and measured the outcomes that they care about. And what they didn't want was for research to devalue their lives and to have implications for coverage that essentially said they were too costly to treat. So as many of you may know, PIPC is chaired by Tony Coelho. Tony was a former congressman from California and is a strong disability rights advocate. He was the original author of the Americans with Disabilities Act, but he's also a patient with epilepsy that comes to these issues with a very personal experience and commitment to making sure that, as the disability rights movement says, nothing about us without us. So we want to talk a little bit today about quality adjusted life years, or as some people call them, QALYs. The quality adjusted life year is a means of measuring healthcare quality. The metric is used to determine whether a treatment is cost effective. And it does that by measuring the disease or disability burden and treatment efficacy and mitigating it. So when you look at the QALY, it'll give a value of 1 to a year in perfect health. It will give a value of 0 to death. And somewhere in between is where most of us fall, especially people who have a disability or some sort of chronic condition. The challenge with that concept is that it will essentially devalue a person's life that's not lived in that optimal health category. So when the quality metric is used, the algorithm essentially assigns a value to the year in the life of, let's say for moderate multiple sclerosis, a 0.5. So the factor by which it will calculate the value of a year lived in the life of a person with multiple sclerosis is 0.5 as opposed to 1, essentially devaluing that life and thereby devaluing the treatment for someone who is living in that state. There are many problems with the QALY. First and foremost, as we just described, the extending disabled life is worth less than extending non-disabled life. But that's not the only problem with the QALY. It also is a process of translating clinical outcomes into utility scores that results in a significant loss of information. So for instance, when it's looking at the incremental improvement in health on treatment, it might be looking at a person who has severe, moderate, or mild conditions. Well, most people don't describe their conditions in severe, moderate, or mild ways. They would describe their condition on different days as being more severe than others. And there's a lot of loss of sort of the nuance of how a person is feeling on a given day or in a given year with the QALY metric. Also, people with disabilities may attach different values to their own health states than the general public. Oftentimes, the health utilities that go into these metrics, they are based on survey data. And as we know, people living with a condition may attach a different value to that condition or to the value of their lives lived with that condition than someone in the general public would. There was actually a very interesting article in Health Affairs recently that I'm happy to share later by Ari Naiman and others, which actually found that there's this tremendous disability bias in the general public, which then would, of course, impact the survey data that goes into those health utilities that inform the QALY metric. Also, QALY-based value assessment is unlikely to account for clinical knowledge on patient variation that's not yet in the research literature. Doctors will often say that they understand how a treatment impacts a patient before the literature necessarily reflects that information. The quality adjusted life year also has significant implications for vulnerable populations. QALY-based models are largely based on randomized clinical trial data that lacks minority participants. That means that their models capture data applicable to white, male, non-Hispanic populations. Without that information, it is impossible for a value assessment then to assess the value of a treatment for those populations that are not part of the database. Also, QALY-based models omit attention to the evidence that differential triggers like pollution and food insecurity may have on the expression of disease and illness. As you can imagine, that has significant implications as we're trying to advance a more equitable healthcare system and one that addresses social determinants of health. So the United States has a significant history of opposition to the quality adjusted life year. In the Affordable Care Act back in 2010, Congress included a critical safeguard that was actually supported in a bipartisan way, prohibiting Medicare from using cost effectiveness assessments to make coverage and payment decisions. The prohibition on QALYs was very clearly stated in the statute that created PCORI and prevents Medicare from using that QALY metric as a threshold for coverage, reimbursement, or incentive programs. Even before 2010, when the Affordable Care Act passed, disability rights laws already included provisions that would protect people from use of metrics like QALYs. Section 504 of the Rehab Act ensures that people with disabilities are not excluded from participation in or denied benefits of or otherwise subjected to discrimination under any federal program. And Title II of the Americans with Disabilities Act extends that protection to programs and services offered by state and local governments. After the Americans with Disabilities Act passed in 1990, in 1992, the Department of Health and Human Services actually denied a waiver that was submitted by the state of Oregon that would have used the quality adjusted life year to determine its prioritized list of services. We'll talk a little bit more about that later because that issue is much more nuanced, but it certainly goes to show that there was a sentiment even in the early 90s that QALYs were a violation of these disability rights laws. It's also important to recognize that in the recent Inflation Reduction Act bill that passed, there was also additional language included to further protect people with disabilities. It essentially states that when looking at the drug negotiation and the fair price, the agency is not allowed to use comparative clinical effectiveness research that devalues the lives of elderly, disabled, or terminally ill individuals. Those are their words. So you can imagine the implications for older adults if they were able to use information that essentially devalued life extension for older people. So we also wanted to talk a little bit about the Protecting Healthcare for All Patients Act of 2022. This is legislation that was introduced by several Republicans in the House of Representatives, including Kathy McMorris Rogers on the Energy and Commerce Committee. We are certainly hopeful that this bill may have legs going into next year, as it would extend the QALY ban to other federal programs, including programs like Medicaid, VA, TRICARE, et cetera. It's also important to note that this is a nonpartisan issue. The National Council on Disability, which is an independent federal agency that advises Congress and the administration on disability issues, they drafted a report back in 2019 that recommended against the use of QALYs in federal programs and in decision making. Since then, the National Council on Disability has also recommended a ban on the use of QALYs across federal programs as part of its health equity framework. So some people may ask, why does all this matter? What's wrong with the QALY? How does it translate into things that I care about? Well, the reason that QALYs matter are, number one, the impact on Part B access to care would be tremendously negative for a lot of patients on Medicare. So this particular study looks at certain treatments: rheumatoid arthritis, MS, small cell lung cancer, multiple myeloma. And in this study, they determined that if we were to rely on studies that are QALY based, particularly by the Institute for Clinical and Economic Review, which we'll talk about, that many patients would lose access to their treatments and have to switch. And the same thing goes for Medicaid. A similar study was done looking at what would happen if the QALY-based cost effectiveness analysis were used as a determination of what Medicaid covers, and similar findings that patients would lose access or have to switch to different treatments. And we see this play out in other countries that rely on the quality adjusted life year metric to determine what they will or will not cover. We see in other countries there are worse outcomes for many types of cancers in particular. We actually have 5-year survival rates that are much higher here in the United States. We also find that people in other countries where QALYs are the benchmark for coverage, they have fewer options for cancer medications. And we also see that their access to newer medications is delayed. So here in the United States, our patients are getting access to newer treatments around 2 years earlier than in other countries. So we worry about cost effectiveness assessments in large part, and particularly the cost effectiveness assessments that are coming out of an organization called the Institute for Clinical and Economic Review, also known as ICER. Number one, they rely on these discriminatory methods such as quality adjusted life years to calculate the cost effectiveness of a treatment, and then to make recommendations to policymakers about how they should cover them, whether they should cover them, whether they should use prior auth and other utilization management strategies, which often, as you know, create barriers then to care. There are also concerns that ICER's studies fail to meaningfully engage expert stakeholders. They don't give them a vote on the treatment and its value. It also fails to consider outcomes that matter to patients and people with disabilities. And this is because if you look at the research literature and you look at a lot of the outcomes that patients will say are important, if those outcomes are not measured in the research literature that is then being used in the value assessment is not measuring things like the impact on caregiving, the impact on someone's ability to sit up in bed, the impact on someone's ability to go to work. Without that kind of information, these studies are not really reflecting outcomes that matter to patients in terms of the value. Also, these studies tend to be very premature, so they're largely relying on randomized clinical trials as a new drug is coming to market. So they don't include any of that real world evidence that could be gleaned on these outcomes that really matter to patients. There's also a lack of transparency to people who are living with the study conditions, whereby, if you or me wanted to go in and really understand how those calculations were made, it's not transparent and it's not readily available. It's not an open source data system that ICER uses. And yet we're very concerned that ICER is looking to increase their role in healthcare decision making. Some of you may have also read in the news that ICER has been opining a lot on the CMS drug negotiation process that was recently passed in the Inflation Reduction Act. It's important to note that ICER already has a role in Medicaid, the VA, and TRICARE. They're also looking to increase their role through state legislation. A couple of examples: the California Healthcare Foundation funded ICER to generate value assessment and policy guides for use in California. And also, we are currently looking at Oregon and their Health Evidence Review Commission, also known as the HERC, where they're considering options to continue using QALYs and ICER studies in their deliberations related to the prioritized list of services. So a lot of the state-based issues are coming out of an organization called the National Association for State Health Policy, or also known as NASHP. So there's a couple of bills that I think have raised eyebrows because they would exacerbate or increase the use of the quality adjusted life year in state-based Medicaid decision making. So first is Canadian reference pricing, which would allow states to directly reference the prices paid for drugs in 5 Canadian provinces. Before applying for coverage by the provinces, all drugs would have to complete a common drug review by this Canadian entity, which uses QALYs. And then secondly, there's been legislation in several states to create a prescription drug affordability board that would essentially allow the state to review and evaluate the reimbursement rate and coverage for pharmaceuticals. The challenge with those bills has largely been around their reliance on third parties like ICER to come up with the benchmark price. State use of cost effectiveness and value has certainly increased, and I think is raising eyebrows and causing a lot of concerns as they look for one-size-fits-all solutions to reduce their healthcare costs. So in New York, we have long seen their use of the quality adjusted life year as part of their supplemental rebate determinations, which obviously has an impact on the conditions that those particular drugs treat. The ones that we're familiar with here are cystic fibrosis and spinal muscular atrophy. Massachusetts, also, their Health Policy Commission has a contract with ICER to develop their framework for determining the value of pharmaceuticals, despite a lot of advocacy from others that arguing that ICER's models are discriminatory. In Oregon, they did actually renew their waiver. CMS has approved it. And the HERC, as I mentioned earlier, is maintaining that they can continue to use the quality adjusted life year as one factor in determinations related to their prioritized list of services. They're actually taking comments now on 2 options to use quality adjusted life years that are due on November 1st. Also, Washington State's Health Technology Clinical Committee makes coverage determinations for selected health technologies based on the available scientific evidence, and that includes QALYs. So we're very excited too to have template legislation for states to consider that would essentially bar QALYs across the board. Oklahoma is a state that did actually pass a QALY ban, and that has kind of become a standard. And so this is the template for that. So if you have advocates in states that are interested in advancing a QALY ban within the state as part of their legislative agenda, I'm happy to flag for you where to find this particular template, which includes really good language that would achieve that goal. So we're very happy to share with you some resources to learn more. I know that QALYs are a really complicated and complex. It's a complex metric and it's sometimes hard to explain. So some of the resources that we have that might actually be useful for you and your advocates are at valueourhealth.org. The template that I just discussed is also at the valueourhealth.org website. PIPCpatients.org as well. We actually do a weekly newsletter that we would love for you to sign up for. And if you're trying to track what's going on in the states with regard to their consideration of bills that would potentially implicate use of QALYs, we would refer you to patientaccessproject.org, where there's a in real time tracker for each state. It's a very useful tool to follow how states are using cost effectiveness in ICER studies. Thank you for having me here today. I'm more than happy to engage with any of you at any time if you have additional questions about the Quality Adjusted Life Year or ICER or what's happening in the states and at the federal level. Please feel free to reach out, and we look forward to doing this again next year.
Thank you, Sara. Great presentation on a very important issue. I'd like to now welcome another good friend and ally of AAKP's, Patricia D'Antonio, Vice President of Professional Affairs with the Gerontological Society of America. Patricia is joining us today representing the Patient Access to Pain Relief Coalition. In 2015, AAKP was a founding member of the PAPER Coalition, and AAKP's Paul Conway served as chair for the first 6 years and remains on PAPER's board. PAPER is an alliance of over 20 medical professional and patient organizations in the pain management policy space. The organization works to educate patients and professionals on safe use of pain medications, and most importantly, PAPER works to ensure your ongoing access to safe, over-the-counter pain medications that are compatible with your doctor's care plan for you and your long-term kidney health. Tricia, the floor is yours.
Thank you so much for inviting me today to participate in the AAKP policy meeting. It's always a pleasure to be here with you, and this year is nothing different, to represent the Protecting Access to Pain Relief Coalition. We have been able to meet in person, and we've been able to meet online, and again, I think this meeting is a great convening for all of us to learn more about how we can participate in the policy process. So let me tell you a little bit about the coalition that I'm representing here today. The Protecting Access to Pain Relief Coalition advocates for public policy to support continued access to and choice of over-the-counter or OTC pain relief medications. And we started almost 8 years ago now, related to an announcement from the FDA where they planned to limit access to over-the-counter acetaminophen. The coalition officially launched in 2015, and we have 22 members. I'm happy to say AAKP is well represented as part of the coalition. So our coalition, we have a board of directors, we have our policy and patient insight council, and then we have our members. And AAKP is represented on our board of directors, represented ably by Paul Conway, who is a great policy person to work with. And I think what's really important here is that understanding that our membership is across different types of organizations. Our members are working directly with patients and advocating for patients. Our members are working specifically in a variety of different areas. So some may be working in aging organizations, some may be working directly for kidney patients, some are working for chronic pain patients. So it's a really robust organization, and it's such a pleasure to be able to work with so many colleagues who are striving to ensure access to over-the-counter pain relief. The last time I spoke with you, we talked a little bit about the coalition structure. Since we spoke last, we have actually formalized our coalition and we have become a 501c4 organization. So we really have started to establish ourselves much more than a group who have come together of different organizations who want to advocate on this issue, in that we've formalized our structure, we've formalized our governance and our operations, and this gives us opportunity to seek funding differently than we have in the past to support how we can continue to educate people about over-the-counter pain relief and the importance of access to over-the-counter pain relief. We continue to be supported by Holland & Knight, who manage our administrative functions. They are a law firm here in the District of Columbia, and they have offices around the country. But we work specifically with a team there for our administrative functions. And we currently have support from Johnson & Johnson Services Incorporated for those administrative costs. And here you can see our membership is broad. So you're not surprised to see, hopefully, the number of organizations representing kidney patients, including AAKP. Also, think about it. We have members here who are Transplant First Academy, Renal Physicians Association. So it's across the ecosystem of those who work with kidney patients. We also have members who work in oral health. And when you think about it, pain management and oral health is so important, and so important that we have access to over-the-counter pain relief when we have that toothache that's really bothering us, right? And then we see members who are from a variety of pain organizations. Now, some represent patients, right? So we have U.S. Pain Foundation, we have the Western Pain Society. We also have practitioners, the American Society for Pain Management Nursing, the Coalition Against Pediatric Pain. And then I want to call out that our members work across the life course, right? So I mentioned some of the pediatric organizations that are engaged, and I myself work for the Gerontological Society of America, where our work is around the study of aging. So that aging life course approach, that we are all aging, and we want to be sure that our vision is actually that we all have meaningful lives as we age. So some of our activities and accomplishments, I think the one thing that we're probably most proud of is because we were able to come together as we had back in 2015 and working as a partner with our government agencies, with members of Congress, with other organizations, we were able to see that while the FDA did not put anything in writing that said we are not going to look at acetaminophen with respect to access to anything over 325 milligrams, we were able to see that they wrote in a letter to our coalition around our safe use initiative, right? Safe use of over-the-counter pain relief, that there have been many ongoing efforts in the research area already, and the prevalence of unintended acetaminophen overdose is very low. Now, the reason that the FDA initially wanted to move forward with limiting access is the concern when there's access to medication and people may overdose on that. And as we have continued to educate people, educate the public about how acetaminophen or Tylenol is not only an individual product, it's also in other over-the-counter medications like cough and cold medications. As we started to educate more people about that, we educated the public, we've started to see some of the issues lessen around overdose with acetaminophen. Another thing that we started to work on, since we had established these relationships with colleagues at the FDA and colleagues at the CDC and colleagues at Health and Human Services, was what specifically should we look at with respect to other reasons that access may be limited, or we need more information for the public around access to these medications? So one thing is over-the-counter monograph reform. And what I would say is, so monograph reform, what it really means is a monograph is what's established for any medication, right? And it's sort of like the rule book for a therapeutic class of medication. So take this where we would say analgesics, right? The over-the-counter pain medications. And this establishes the active ingredients, the doses, what needs to be on the label, how the medication is recognized as safe. So we actively worked to increase the FDA's ability to make changes. So prior to 2019, prior to that, if you wanted to make a change on this monographs, you actually needed a really daunting process. So it was very hard to get those changes made. And as part of some of the COVID activities, the CARES Act, which is the Coronavirus Aid, Relief, and Economic Securities Act, when that was passed into law, it changed how the FDA considers new over-the-counter products and those label changes. And it removed some of the burdensome processes that are involved with being able to create that label change. Now, the law has passed, and we continue to monitor for how that could impact us for some of our over-the-counter medications. And that really gets into what's next on my slide about the weight-based pediatric dosing of acetaminophen. And what I would say to you is, how many of you have ever woken up in the middle of the night with a young child under the age of 2, and they seem to have a fever or they're sick, and you go for the over-the-counter acetaminophen, and it says, under the age of 2, call your healthcare professional. Well, at 2 a.m., who can you call, right? So there has long been accepted practices around weight-based pediatric dosing, weight-based dosing for children under the age of 2. It's even gone past some of the FDA advisory committees, and all agree on this. Well, the effects of OTC monograph reform means that now the FDA can take a look at weight-based pediatric dosing so that we could see on the label how you would dose this medication for somebody under the age of 2. And actually, it would be under a certain weight, not under a certain age. And so what I think is really good, and we continue to engage, is to ensure that this monograph actually does get updated for all of us so that the label change can happen. The other thing that you may or may not realize is that while we know that chronic pain is widespread, and it is the leading cause of disability across our nation, data is not systematically collected anywhere on chronic pain prevalence and the related factors, nor is it housed publicly so that researchers, health departments, so that we can all understand the impact of chronic pain. So we have continued to advocate for the Centers for Disease Control and Prevention, or CDC, to have an ability and an authority to collect this data and be able to share this data so that we can actually do the research to find out, really, what does it mean that people have chronic pain and what kind of healthcare costs are associated with that pain management. So we continue to meet with colleagues at the Department of Health and Human Services, the CDC, members of Congress, to advance this type of policy agenda. And one last thing I wanted to raise with you as we're here today, a recent abstract that was published with Pain Management Week, which is a large meeting that specifically looks at different issues in pain management. But this project and research study was done on the role of over-the-counter pain relievers and self-care in America, right? Changing that healthcare landscape. I think over the last few years, we've all had to think about self-care a little bit differently because of our access to different healthcare providers. This was published by an organization, APCO, and really they conducted interviews of a representative U.S. adult population. And here are some of their findings. They found in asking this question of approximately 2,500 patients, it's 2,499 actually, they conducted some surveys. They learned that half of the participants report using over-the-counter medications. Shouldn't be surprised, right? We all use vitamins, pain relievers, different types of over-the-counter medications. But pain relievers were the most commonly reported over-the-counter medicine in participants' homes. Acetaminophen and ibuprofen, Tylenol, Motrin, right, were the analgesics most commonly used. And people reported they used them to manage aches and pains, back pain, arthritis pain, fever. And 73% of those people, that's 3 out of 4 participants, reported using acetaminophen at least a few times over the previous 6 months. Now, I don't want to steal all the thunder of the researchers because we certainly were not the researchers, but I think it's important to know that this kind of research is out there because what this suggests is accessibility and effectiveness of over-the-counter analgesics, acetaminophen, allows individuals to appropriately self-manage their health and quality of life. Now, think about that, how important that is when we know that there was opportunity at some point that it was possible that access to over-the-counter pain relief would be restricted. So again, comes back to the mission and the role of the PAPR Coalition. So I just wanted to bring this to your attention. Again, it's always a pleasure to be here. I hope that you'll take a look at our website, paprcoalition.com. It's on the slides. We have some webinars and briefings that are up there that we've conducted over the years around access to pain relief, access to over-the-counter pain medications, including the impact of telehealth on our system and how that has changed and how that will change moving forward. If you have any other questions, please, through our website, send a message to us. If you are part of other organizations or other coalitions that you think should be part of the PAPR Coalition, we would invite you to send a message, let us know. One of the webinars that we know will be upcoming in early next year will be related to the study I just referenced. So when that becomes available, we'll be sure to let you know. And with that, I just want to say thank you to colleagues from AAKP. It's a pleasure working with you. It's a fun coalition. And I would just want to say thank you for all of your advocacy work that you do as well as part of AAKP.
Thank you, Patricia. That was a great presentation. Now, I would like to introduce Michele Kimball, Executive Director of Kidney Care Partners, or KCP. KCP is a collaborative of kidney community professional organizations and industry partners. This organization operates under the leadership of AAKP's longtime friend and ally for greater patient care choice, Mr. John Butler, the CEO of Akebia. John shares AAKP's interest in patient access to safe, new care innovations, and also shares our determination that these innovations are reimbursed and paid for by CMS and other payers so patients have timely access. Michele, it is a pleasure to have you join us today. I turn it over to you.
Thank you. Hello, everyone. I'm Michele Kimball. I've been a patient advocate for my entire career, and as you know, I now serve as the Executive Director of Kidney Care Partners. Kidney Care Partners, or KCP as we are known, is the nation's largest nonprofit, nonpartisan coalition of more than 30 organizations representing patients, professional care providers, and a wide range of kidney care stakeholders. At KCP, we are working together to improve the quality of care, choice, and access for individuals living with kidney diseases. KCP members are committed to meeting patients' needs at every stage along the care continuum, and our diverse membership shares a broad vision across the full spectrum of the disease cycle, from education and prevention to early intervention, therapeutic treatment of chronic kidney disease and dialysis, and finally, to transplant and post-transplant care. Our policy priorities this year have focused on supporting patient choice and access in coverage options, treatment modalities, and innovative treatments and services. We've also been working to transform the Medicare ESRD benefit so that it moves dialysis care into a more patient-centered program. And we've been advancing quality to promote transparency and patient-centered decision-making, as well as working to ensure access to care for individuals living with kidney disease. As many of you know, chronic kidney disease is an illness that affects an estimated 37 million people in the U.S. That's more than 1 in 7 adults across the country, or nearly the size of the entire population of California. When you use that analogy, it is quite daunting how many people in our country are living with this disease. But despite the alarming statistic, investment in kidney disease research and therapies lags in comparison to other modalities. Sadly, our community historically has been among the lowest government investments in research and development and reimbursement for care. This impacts overall kidney innovation investment, which is reflected in the fact that we have historically had one of the lowest rates of new drug applications submitted to the U.S. Food and Drug Administration, particularly when compared to other therapeutic areas like oncology and cardiology. Some say this dates back decades to the lack of government investment in foundational and institutional research on kidney disease, tracing back actually to the National Institutes of Health, which has invested so little, despite the fact that kidney disease impacts so many, literally tens of millions of Americans. And looking at present-day payment, our largest reimbursement program, Medicare, provides little to no incentives or funding for investment in innovations or even earlier disease intervention. And while a program like KidneyX, a private-public partnership created with the U.S. Department of Health and Human Services to accelerate innovation, is a really good first step, and it gives much needed attention to this issue, a government investment of only $5 million is really just a drop in the bucket. So on one hand, we're seeing one department like HHS promoting programs like KidneyX to accelerate access to innovations. But on the other hand, the FDA is rejecting most of the drugs for kidney disease that it has reviewed in recent years. This, despite seemingly meeting trial study endpoints. And this is even for drugs that have been approved in other countries, such as Japan, South Korea, and throughout Europe. The FDA's puzzling rejections have prevented medications from reaching patients, further casting a pall over future investment. The FDA needs to closely examine whether it is applying the appropriate benefit risk assessment for new drugs intended for this population. So we must redress this imbalance, and we must address it right now. Patients can't wait. Unfortunately, such barriers to treatment end up affecting our most vulnerable populations, especially since kidney disease is more common among people at age 65 and older, in women, and in Black and Hispanic adults. According to the Centers for Disease Control and Prevention, Black individuals are nearly 3.5 times more likely than white individuals to develop kidney failure. This accounts for 35% of all of those with kidney failure, despite making up only 13% of the population. And Hispanic individuals are nearly 1.3 times more likely to be diagnosed with kidney failure compared to non-Hispanic individuals. As a nation, we have to address these inequities. The absence of sustainable long-term reimbursement for innovative treatments in the end-stage renal disease prospective payment system only worsens these inequities. So, this is why Kidney Care Partners is highlighting barriers to innovation and policy concerns that I know we share with AAKP. We are specifically raising issues relating to misalignments in payment and reimbursement policies that provide resources and incentives for innovations. KCP has long advocated for a sustainable long-term pathway to support innovation in the bundled Medicare payment system. This takes time. In the interim, we successfully recommended and advocated for the transitional drug add-on payment adjustment, known as TDAPA, which provides a short-term pathway for adoption of new innovative products. It's a step in the right direction, but still permanent long-term funding is needed. KCP also recommended and worked closely with CMS to craft policies that add money to the base rate for certain new drugs. And now we are also focused on that important issue of CMS increasing payment rates after the TDAPA period ends. Earlier this year, a CMS request for information that we responded to was an important first step in defining the policy options that we are asking CMS to adopt in the 2023 rulemaking cycle. Hopefully, CMS agrees. Additionally, the Independent Nonpartisan Medicare Payment Advisory Commission, or MedPAC, that advises Congress along with our kidney community, has consistently raised concerns about the current ESRD PPS adjusters not being appropriately targeted to address higher cost patients, especially those with multiple disease conditions common among individuals with kidney failure. Fortunately, some leaders in Congress agree and have urged CMS to do just this. Senators Ben Cardin and Roy Blunt and Representatives Terry Sewell and Suzanne Delbene recently sent a bipartisan letter to CMS Administrator Chiquita Brooks-LaSure to address the Medicare prospective payment system and to not only adjust the payment rate when new innovative products are added to the payment bundle, but to most especially ensure the payment adjustment reflects the significant increases all of healthcare is experiencing in labor costs and workforce shortages. And KCP is also taking action. Our bipartisan community legislation, the Chronic Kidney Disease Improvement in Research and Treatment Act, would require CMS to review current reimbursement policies to assess these costs. Specifically, this bill would create an economically stable dialysis infrastructure and incentivize innovation by refining the payment system to improve accuracy in payment and support innovative therapies. The bottom line, for far too long, payments have been inadequate, and Medicare's ESRD program currently has no sustainable pathway to incentivize improvements in kidney care for patients. This needs to change now. As a community, we all know what the problems are and we know what the solutions are. We have our ear to the ground on the front lines of care, and it's you, the patient advocacy community and leaders who help guide us and inform lawmakers of problems and obstacles to patient-centric solutions. But it takes time. And it takes alignment of government actions and policies across HHS and CMS, the FDA, Congress, and other agencies for meaningful and measurable change and progress. We've got to all be in sync to deal with what I regard as a crisis, and it must be addressed yesterday. Why? You know this better than any of us. The fact of the matter is, kidney disease patients can't wait. They need access to innovative therapies to expand treatment choices and improve the quality of their lives now. Patients can't afford to lose access to treatment options due to a lack of investment in research, compounded by inadequate payment policies that actually disincentivize the development of innovative products and therapies. This is just wrong. The time for action is now. The nearly 40 million Americans living with chronic kidney disease are worth it and deserve access to the very best care. Fortunately, we have organizations such as AAKP and KCP who are on the front lines fighting the good fight and making a real difference. So I thank you for all you do, especially to educate our policymakers on issues important to all of us. And I am delighted to have had the opportunity to share some of these priorities and the focus of Kidney Care Partners with you today. Thank you.
Thank you, Michele. We appreciate you joining us and sharing your insights. Now, for a final session speaker, I'd like to welcome an AAKP friend and ally, Dr. Edwards Abrahams, President of the Personalized Medicine Coalition. I am honored to serve on the board of the PMC and work alongside Dr. Abrahams and many of the leading companies focused on transcending status quo kidney care with better therapeutics to delay disease progression and stop kidney failure. Dr. Abrahams, thank you for joining us. and I'd like to turn it over to you.
My name is Edward Abrahams. I'm president of the Personalized Medicine Coalition, an education and advocacy organization created to promote the paradigm in medicine we call personalized medicine. I very much want to express my appreciation to Richard Knight and AAKP for inviting me here today to discuss telemedicine, a very important new technology that has been introduced into healthcare, which facilitates personalized medicine, getting better outcomes for patients that we've never been able to reach before, because we're willing to integrate new technologies into healthcare that will facilitate reaching more patients than ever before. Despite the consensus that personalized medicine approaches have significant value, their implementation and consequently patient access across the United States is unfortunately highly variable. But as I said, telehealth can improve patients' access to personalized medicine by making it easier for a patient to connect with his or her healthcare provider, including providers a patient would not normally have access to at their current healthcare institution, to discuss appropriate treatment and prevention options, which may involve diagnostic testing, as we at the Personalized Medicine Coalition hope it will. Because again, linking therapy to diagnostics is critical to get the best outcomes. And telehealth, I want to say again, is one way we can do that. Over the past few years, PMC and its patient advocacy organizations, especially AAKP, have been raising awareness about the potential for telehealth to help us increase patient access to personalized medicine. We have advocated for policies supporting continued telehealth flexibilities so that healthcare services continue to benefit patients, despite some who would now, following the pandemic's closure, let's hope, remove the capacity to use telehealth in the future. At the beginning of the pandemic, Congress enacted waiver authorities in pandemic response legislation to enable broad access to healthcare via telehealth. This allowed Medicare to pay for hospital or office visits across the country starting in March 2020. According to a report released in December 2021, telehealth visits increased healthcare for patients 63-fold, from approximately 840,000 to 52 million the following year. Patients face many challenges in accessing personalized medicine and the appropriate testing services, ranging from coverage and reimbursement policies and socioeconomic determinants of health to provide varying degrees of expertise with genomics and navigating related options for patients. Telehealth promises quicker, timelier, and broader access to personalized medicine, which may be especially helpful for individuals who travel long distances to reach their healthcare providers, especially in rural area. And some patients, as we know, face other logistical challenges getting access to care. So again, telehealth is critical to facilitating better healthcare, especially for kidney patients. In the future, telehealth could facilitate education on chronic kidney disease and dialysis, transplant evaluations, as well as aspects of home dialysis training and monitoring to improve utilization and retention on home treatments for kidney patients. Telehealth also has the potential to reduce disparities in access to personalized medicine by mitigating barriers in rural and other difficult to treat healthcare settings, such as distance to a treating physician, and by mitigating barriers that disproportionately affect individuals from minority and low income communities, such as transportation. Telehealth is not free of its own access challenges, such as internet connectivity and availability of devices to perform telehealth, digital literacy, and socioeconomic barriers, which can prevent patients from engaging with their providers via telehealth. These challenges are important to note, as kidney disease happens more often in African, Caribbean, and Latin American settings than other typical settings for healthcare. And the key here is we want to make sure that we overcome those barriers, as it's important to develop principles of universal health care, which telehealth is a major instrument. Now, prompted by the pandemic, the healthcare community and policymakers are also considering how to advance decentralized clinical trials, which are going to be very important in the future to ensuring the development of personalized medicine, which to date have not been able to access the minority populations as much as we would like. So again, telehealth is going to be a very important instrument to improve healthcare. For telehealth to improve patient access, though, it's important to minimize the restrictions as telehealth flexibilities are extended or made permanent until their benefits are fully understood. PMC does support ensuring that Medicare addresses issues of fraud, but we want to make sure it does so in a way that does not limit this very important advance in increasing access to healthcare and therefore personalized medicine. PMC has cautioned against proposals being circulated in Congress that would require ordering a provider to have a face-to-face encounter with a Medicare beneficiary within the past 6 or 12 months, or some other arbitrary period, before Medicare could pay a claim for reimbursement, for example, for a quote-unquote high-cost laboratory test. Diagnostic tests, including laboratory and genetic tests, would be impacted by this proposal. These tests are the foundation of personalized medicine's approach to healthcare. Again, we want to know for whom a therapy is going to work and for whom it won't work. And getting access to these diagnostic tests is going to be and is critical. Any limitation on them, because we're concerned about fraud, for example, would be a setback generally for patient care and development of a better healthcare system. We do understand the rationale for an in-person requirement is to prevent fraud, but Medicare, we argue, has a host of other tools that it can be used to address access issues, to address fraud and abuse and permit greater access. Protecting the Medicare program and its beneficiaries from unnecessary spending and potential fraud is important, as I noted, but promoting Medicare beneficiaries' access to high quality, appropriate care, we argue, is more important. And we want to continue to see that developed. And we don't want to see these arbitrary programs, arbitrary proposals to limit access to telehealth, which has worked and will work better in the future, limited. With the end of the healthcare emergency hopefully ever closer, we're at a critical moment to shape the future of telehealth and to use it wisely to promote the principles of personalized medicine. We must do so in a way that increases access to personalized medicine and benefits especially kidney patients in the future. So again, I want to thank AAKP for this opportunity to share with you our views. And I also want to thank AAKP for being part of the Personalized Medicine Coalition and effort to advance this new paradigm, which we think holds so much promise for patients in the future. So thank you very much for this opportunity today.
Thank you, Dr. Abrahams. A great presentation to close out the session. Now, I'd like to give a big thank you to all our session presenters for sharing their time and expertise with us. AAKP will be considering many of these topics as we prioritize our issues for the 2023-2024 policy cycle.